This is Duke University.
Good afternoon, everyone. I'm Deborah Jensen, Director of the Franklin Humanities Institute, and I'm going to begin this introduction on a playful note that although I think up to 100 more people would have signed up for Jonathan Metzl's keynote if we had been able to secure a larger venue, which obviously we were not, this distinguished speaker himself represents only half of our original ambition. How might one solve this riddle? We had invited Dr. Metzl and his structural competency collaborator, NYU anthropologist and psychiatrist Helena Hansen, to speak to their important work theorizing a new medical engagement with stigma and inequality, in part as an interdisciplinary team. Doctors Hansen and Metzl are gearing up for such multiple events on their work that this was like asking for the moon, and yet we got half. Similarly, their work has shown the ways that each biomedical patient is herself a small fraction in the collective equations through which medical problems, including hypertension, obesity, or depression, may be downstream effects of larger societal decisions about transit systems, food distribution networks, and their foundations, in turn, in larger patterns of income inequality and stigma. How are healthcare providers, patients, communities, medical schools, and politicians preparing to address that new aphorism that individuals' health may be as determined and revealed as much by their zip code as by their genetic code? And how are the humanities and academia ready to engage? And more importantly, how can the humanities, whether in academia or in the larger society, support individual and community health? Today's Mellon-funded conference is co-sponsored by the FHI Health Humanities Lab, which is collaboratively supported by Duke University Provost Sally Kornbluth and visionary, community-facing Duke Health Chancellor Jean Washington. The training trajectory of Jonathan Metzl shows the true complexity of expertise in health humanities and its outreach to the communities around structural competence. He completed the BA-MD program at the University of Missouri. Subsequently, he did an MA in American Poetry at Stanford University on the poetics of mental illness at the same time that he completed his internship in medical psychiatry. While he went on to his psychiatry residency and a fellowship in cross-cultural psychiatry at Stanford, he completed the PhD program in American culture at the University of Michigan, where his doctoral advisor was the noted French studies and women's studies scholar Donna Stanton. So he was literally in two places at once. Well, not literally, but definitively not half, but double. He has been a professor of psychiatry and women's studies at the University of Michigan, and he is currently Frederick B. Rentschler Professor of Sociology and Psychiatry and Director of the famous Center for Medicine, Health, and Society at Vanderbilt University. He founded the term structural competency in his 2010 book, The Protest Psychosis: How Schizophrenia Became a Black Disease. That monograph was preceded by his 2004 book, also a bestseller, Prozac on the Couch: Prescribing Gender in the Era of Wonder Drugs. He has several co-authored and co-edited books, including Cultural Sutures, Medicine and Media, and Against Health: How Health Became the New Morality, and additional very notable special issues, and of course many dozens of articles. If we could patent his scholarly efficacy or clone his educational pathways, Sigh. So please join me in a resounding welcome for Dr. Metzl's keynote talk, Structural Competency, Assessing a New Paradigm for Race and Racisms in Medicine.
Well, thank you so much. I'm really so delighted to be here, and I would be delighted to be cloned. So, if the other clone could do like the committee work and respond to emails and stuff like that, that would be awesome. And then I could just hang out here. This is great. But it's really such an inspiration, both the conference in and of itself, and also just to see where this field has gone. From a field that started off saying, oh, some doctors should read more Chaucer to make them more sensitive, to like a real field of like expertise and knowledge. And a two-way knowledge flow. It's really exciting. I'm delighted also to talk about structural competency and to represent half of the moon, as it were. I'm really delighted about that. I should also give a quick shout out because between when I coined the term in the protest psychosis and the work Helen and I did, the work was also highlighted by Priscilla Wald in her American Studies President's talk and wrote about it and talked about it in some special issues. So there's been kind of a lineage along the way. But I think that really the field of this, whatever followed from this, really started to take off in the aftermath of our article in 2014, where Helena and I were really talking about this question of what is it that cultural competency is missing, and how can medicine think more directly about these issues? And I think that really led to a bunch of other publications and seminars and special issues, as you just heard. We've published in special issues ranging from academic medicine to a series of bioethics issues. We've addressed topics ranging from discrimination and poverty to kind of branched out now, and the field is kind of taking on its own life in queer studies, which I think is very nice for us. It's now working its way into urban studies as well, and people who are working on cities and the health of people in relation to cities are starting to do that. And it's also, I think, slowly starting to get some recognition beyond the walls of the academy as a kind of new heuristic for some of the issues that I think were very beautifully and kind of notably articulated in the panel preceding this one, which I thought did such a great job of highlighting many of the issues that are at the nexus of kind of race and health and illness. For my talk today, I want to first just give three kind of jumping off points for what I think the main narratives that structural competency is intervening into, kind of common sense narratives that may have started in medicine and medical education that would seemingly make sense, but we've tried to kind of rupture those narratives. So I'll talk a bit about those narratives, and then I'm going to talk a little bit about research we've done, kind of on the ground research in structural competency at Vanderbilt. And so, first, thinking about the medical humanities, I think that really the long-standing assumptions that I think we're trying to engage with and talk about and think about in structural competency, and the first one is that it's not like we don't think this anymore, but I think there was a kind of common assumption that there was a thing called health, and it's a universal good. And if you look at, for example, psychiatric or medical textbooks from earlier generations, it's like health is good. It's the absence of disease. It's the freedom from illness and pain. And I think it's also important because that was a traditional kind of intervention point for medical humanities. And so there was this idea that we were hearing about it a little bit before. But this idea that the surgeon is not sensitive enough about the health, and so if they just read some Chaucer and read Swan's Way or something, they become much more nostalgic and still have the hands of a woman, as we just heard, and stuff like that. Now, there were benefits to that in a certain kind of way. It was probably the very early point of an interdisciplinary engagement. I think that the problems with it, beside what I'm about to say, is that it created a kind of structural hierarchy in which one discipline was in the service of the other. In other words, here's hard science and medicine, and here's kind of the feminizing humanities that's supposed to kind of make, in the service of medicine, kind of feminize medicine or make doctors more sensitive. And I think that framework itself was kind of problematic in a way, but it was the beginning of a particular conversation. I also always kind of wondered, what if the doctor read like Mein Kampf? Wouldn't that make them like more, homicidal or something like that? And so we were very selective about the values that we wanted wanted physician readers to garner from literary works. But I also think that the point is that this idea of everybody wants health is pretty darn complicated in our present political moment, in that we've got all of these messages around, and it turns out that health, this thing that we thought we all agreed on at some earlier point in Elysian time, it turns out we can't really agree on what health is at this moment. And if we can't agree on health, we can't agree on healthcare. One organization or body wants to provide healthcare, another will give you the creepy Uncle Sam speculum of anti-Affordable Care Act advertisements that were running and are now coming back. And so this idea that we all agreed on something that was health, even if anybody believed that, has certainly been ruptured over the past 10 years in this country, at least. At the present moment, we've got a president who's trying to upend health in order to make a political point and change a creation of legislation. And so I think it's quite known, really, on people of all sides, that this kind of rupture of the Affordable Care Act and killing off the markets and things like that are going to make people sick. And so this idea that just here's good health and we all want it is really not playing out, at least in the American political spectrum at the particular moment. Now, beneath this assumption about health as being a democratic issue or a Republican issue or a libertarian issue or any kind of other issue, there are different ideologies about whose responsibility is health. How do you define health? Who takes care of health and factors like that? And I think this has been playing out for a while in the American political spectrum, not to the extent that it does now, but certainly over the past 10 years, there have been lots of examples of this. My favorite one was when Michelle Obama was FLOTUS, miss her, and she was giving a talk to the NAACP, actually, in St. Louis, and basically started her anti-obesity campaign at the time by saying, we want our kids to exercise, and it's really good to have, health built in, activities built into their school experience, and things like that. And basically also saying dessert is not a right. I always laugh. It's like desert is not a right. And as a way of introducing her anti-obesity campaign. And the next day, Sarah Palin, who used to be a politician, then pounced on the First Lady's health message and basically went out to schools, actually all white schools in Pennsylvania, with brownies that I don't think she made them, somebody else made them, but she was giving out brownies to the kids. And basically the idea was health isn't the government's thing to decide, it's basically the parents and stuff like that. And also, hey kid, have a brownie, something like that. And so we've had these tensions for a while, and it really reflects, I think, widespread and often differing assumptions about modes of sense-making, about control, about autonomy, really things that are reflected and certainly right now amplified by politicians, but that in a way reflect deep-standing local traditions and assumptions about this question of who's responsible for health and what does it mean to have health. And I'm kind of learning this firsthand. I'm writing a book about whiteness in the South, and I've been doing a lot of focus groups across the South with white Americans in Tennessee and Kentucky, and hearing people who have medical illness saying they don't want the Affordable Care Act because they don't want the government in their business and stuff. And it's one thing to kind of know that kind of thing, but when you hear somebody who's got liver failure or congestive heart failure telling you that, you think, oh my God, here's an ideology, whether or not I agree with it, that's so powerful that this person's willing to forego life in a certain kind of way, forego medical treatment because this ideology of hierarchy or racism or autonomy, whatever it is more powerful than the assumption that is common to many other places, which is, gosh, if you're sick, you should go to the doctor. And so, in a way, there's something very powerful about these narratives that's not just a top-down narrative, it's also a bottom-up narrative. Now, health, it has valence in other arenas, political or ideological ones as well. Health is certainly a term in popular culture. This semester I'm teaching a class called Men's Health and the Politics of American Masculinity. And I start off by asking my students, so what are the men's health issues? And they'll be quiet for a minute, and then somebody will be like, prostate, they're like in college, they couldn't find a prostate if it fell off a tree, and they'll be like, oh, whatever. And then I'm like, okay, for next class, go to this thing we used to have called a bookstore, and go down and just look at what the magazines are for men's health, and tell me how many of them are talking about the prostate, for example. And what they see is actually men's health is aligned not so much with the absence of disease. Instead, it's like we used to traditionally think about women's magazines. So things like abs of steel and buns of steel and, dressing right and things like that. And so in a way, this ideology of health, I think, is really pervasive as an aesthetic component. Health is also often tied to morality. This is a image from a long-standing multi-state tobacco quit line. And basically, they were trying to get people to stop smoking. And so they weren't saying, like, you should stop smoking because you're going to get lung cancer and you shouldn't smoke. I probably shouldn't say that in North Carolina. But instead, what they would do was they would perform these kind of guilt trips on parents by having kids speak in adult voices. And these little kids' voices would say, I have a 3-pack a day habit and stuff like that. And these kids' voices were basically, this is how much you're inhaling because you're around parents who smoke, if you're in the car, in the house, or something like that. And the assumption was that people who smoked were not just affecting their own health. Instead, there was a moral failing because they were also bad parents and things like that. And so there's a morality around health that Anna Kirkland and I wrote about a lot in that Against Health book that I think is also something that just gives it a particular cathectic charge. Health is also an economic imperative. And so here's an article from the Wall Street Journal, and I love this article, actually. I mean, it's sad and tragic, but basically Pepsi was selling Cheetos, and it turned out, man, Cheetos are really bad for you, which sucks. I mean, if there's this makes me believe there's no intelligent design in the universe, because if there was a creator, Cheetos would be good for you, but they're not. They're really bad for you. And so it turned out they were selling these really big bags of Cheetos, and then they had this idea to sell healthier quarter bags. And so they were 25 cents, and they sold them at bodegas. And the only thing they changed was that the bag was smaller. And so they called them healthier snacks because people were ingesting fewer Doritos per capita, or whatever the math term is. And so fewer Cheetos and fewer Doritos, but it was also great for their sales. And so in a way, this economic health and this claim of health was inversely proportional to the health of the company and sales and factors like that. And so the point here is that even though maybe once in some time that probably may or may not have existed, we thought about health as being this one thing, the absence of disease, health turns out to be a lot more complicated than we expected because it can be stigmatizing and colonizing, normativizing, medicalizing, consumerist, all these factors. And so in a way, there's a need for a more complicated understanding of health than I think we originally assumed in medical education, in medical humanities, and certainly in medicine itself. Now, we also used to think that a disease is an abnormal condition affecting the body of an organism. It's constructed to be a medical condition with specific symptoms and signs. Now, I'm a doctor, and I totally agree with that. And I don't think anybody as a doctor or a patient wants to go to a doctor and say, hey, doctor, I have some specific signs and symptoms. And you don't want the doctor to say, well, sir, you're suffering from a socially constructed condition, and we need to change society, not treat the individual. We also don't want the doctor to say, man, never seen one of those things before, something like that. We want the doctor to be an expert in those signs and symptoms. And so on one hand, I agree with this idea that a disease is an abnormal condition and that there are signs and symptoms that we always want to get better at assessing and judging. And at the same time, I also think that this conference itself and the work that many great people are doing at this conference is reflective of the outstanding work that I think people are doing in medical history and bioethics and anthropology, sociology, critical race studies across the board that really talks about the ways that you really can't tell a straightforward history of an illness in the present day without taking into account the factors that I think are, prevalent in constructing that illness, factors about gender and race and socioeconomic status and things like that. And certainly I think that as time has gone on, we've become more adept at telling those stories. And in fact, at least in this part of the campus, you couldn't tell a history, you couldn't tell a history of an illness without assessing those matters. And I think that it's important to note because back in the, the quote that I had up here was from Cecil's textbook of medicine from 1955, and you didn't know any of this stuff at that time, and now it's kind of de rigueur for telling the histories of illness. And certainly this has been a part of my own scholarly work, which I just can't help but take a little side note into before getting to the real topic of the talk. And that is that, I've worked on mental health, and so the work that I've done really plays out in relation to these issues. The first book that I did did the Prozac on the Couch, looked at this question of women, the assumption across kind of biological psychiatry that women are twice as likely as men to suffer from depression. And there were all these PET scans and brain scans that ostensibly showed that men and women have different brains. But it turns out like the science wasn't incredibly convincing about that. And it wasn't like there was any blood test or, X-ray or anything like that. And then I started looking back through the history of this illness, major depressive disorder, and it turned out there was a pretty important cultural shift that happened that reflected this shape of what depressive illness was. And I'll give you two examples from history. In the 1950s, the 1950s were a time when, for whatever reason, society was really worried about mom. Men had come back from the war. We actually won that war. Our economy was starting to do well. I don't know why this was. Maybe women had gotten too powerful in the domestic sphere, but there was this pathology called momism, coined by a guy named Philip Wiley, and the whole idea was that women were becoming too powerful, and they were emasculating their poor little husbands. And so you would see this representation across a wide array of different kinds of venues, but here's a famous Osborne cartoon from The Nation. Also, if anybody was forced to read stories like The Secret Life of Walter Mitty, in high school, things like that. This idea, basically, that mom has gotten so big and mean and powerful that she's dragging around poor little dad who has no say in the matter whatsoever. And if you look at pharmaceutical advertisements from the American Journal of Psychiatry, again, as we heard in the last panel, a really big-time journal from this period, you'll see that if people were reflecting this ideology at the time of mom being more powerful, all of a sudden you'd see representations like this, in which this is an ad for a sedative, a major sedative, Deprol, and at first glance you'd think that this doctor should be the authority figure in the image. He's got these pens, the cool license, that white coat. But I think somebody who was coming out of this visual iconography would have known that kind of phantasmagorically foregrounding a large kind of married woman would have upended that power structure. Now, if you don't believe me, just buy my book, basically, because I've got hundreds of these examples of ads for major tranquilizers in which basically poor dad just wanted some peace and quiet to eat his peas at the end of the day, but he's got to come home and deal with big bad mama. And I just can't help it. My second favorite ad of these actually comes from a Librium advertisement, again from the American Journal of Psychiatry from the late 1950s. And basically this is an ad for a tranquilizing medication, essentially, it shows a ring of kind of momist moms, and so here's mom up there who's so mean that she can't even stay in the circle that is prescribed for her by society. Here's daughter down there who's kind of like mom in training. Wife, mother-in-law, they're all so mean. They're all angles, right? They're all elbows. They can't stay in their place, and they're surrounding teeny little him who looks like vintage era Pee Wee Herman, and teeny little son down here in the bottom. And so this assumption, basically, that momism is a mental illness that needs to be sedated. Now, I'll just give you one more because I love this stuff. The 1970s, an era where we weren't so much worried about mom. We were worried about feminist women in revolt. A woman needed a man like a fish needed a bicycle. We were upending the male-female role system, upending patriarchy. And at that time, single women were rejecting the kind of traditional norms. And at that time, if you look at anxiety medications, antidepressant medications, you see stuff where the mom is gone, but you see stuff like this Valium advertisement that basically the way I read this is from the early 1970s, is that the outside castrating woman is the kind of feminist, teeth-gnashing kind of woman, and then as she moves centripetally or centrifugally, I can't remember which one it is, toward the middle, she gets the Valium, she calms down, and her mouth is closed by the middle. So there's that. Then my favorite ad is another ad from 1972 from the American Journal of Psychiatry, and this one shows a visual narrative of a woman named Jan who had a happy childhood playing tennis with her dad, and then she had basically a series of kind of loser Tinder dates. So she had Joey up there in 59, Charlie in 64, kind of drunken, groping Bunny here at the office party, and then she's alone on the ship there in 1970. And when I first saw this ad, I thought, well, Jan must have just taken the plunge, right? I mean, she was so upset about this whole thing. But then you read the text and it says, the purser under a cruise ship took the last snapshot of Jan. You probably see many such Jans in your practice. The unmarrieds with low self-esteem. Jan never found a man to measure up to her father. Now she realizes, present tense, she's still alive, that she's in a losing pattern and that she may never marry. And it's because she is 35 and single and unable to find a man. In other words, she's a feminist. Now, we see this again and again and again throughout time. In the 2000s, it was basically the Hillary Rodham Clinton motif of what does it mean to go to get a job, and does the kid get his mommy back from depression or from work? Either way, affects her is the treatment in either case. And so the point here is basically that gender politics reflected and shaped, I think really deeply shaped, our idea about what an illness was. And I'll just say as an aside that my next book, Protest Psychosis, talked about this in relation to schizophrenia, again, an assumption of it being a biological illness. And because we think of schizophrenia in terms of dopamine and brain matter and size and all these kind of things, you should think that schizophrenia is an illness that should occur in all people equally, but it turns out black men are 5 to 7 times more likely to be overdiagnosed with schizophrenia. And again, there was a historical reason for that. What I found in that research was that there was a shift in the ways that we defined schizophrenia. In the 1950s, we thought of it as an emotional disharmony with unpredictable disturbances and regressive behavior. Now, what do you do when you regress? That's like you sit at home or play your guitar, stuff like that. But in 68, we changed the diagnostic terminology, and all of a sudden in 1968, this is from the DSM-2, came out, probably not the best year to add this stuff to a diagnostic manual, but hostile and aggressive attitude, projection. And it said the patient uses the mechanism of projection, which ascribes to others he cannot accept in himself. In other words, if you project, you're not sitting at home playing your guitar, you're like smashing your guitar over some other dude's head. And it turns out that when this happened, all of a sudden, all the iconography about schizophrenia changed. Here's an ad from the Archives of General Psychiatry from 1968. And you can see that basically these kind of assumptions, hostility and aggression, projection, are used to paint the new face of schizophrenia as kind of a James Brown-like character who's got a fist, but it's not the Black Power Mexico City solidarity fist. It's the inverted, I'm going to punch you in the nose unless you give me some Haldol kind of fist. Also, this is an urban scene, and it looks like almost like flames on the page, and it's showing up about 3 months after the Detroit riots and the Watts riots and other factors like that. So again, here's what's happening is that there's this frame shift and this assumption. And I guess the point here, which I'm trying to kind of illustrate, is that in a way, the straightforward notion of illness is ruptured when you take things like race and politics and gender into account. So that's story number 3. I will get to structural competency, I promise. But number 3 is the assumption that race happens in exam rooms between doctors and patients. Now, certainly it does. And we heard a lot. I think that the last panel was very, very moving in that way about kind of these assumptions, about the automatic assumptions that doctors and patients make when they're in exam rooms and kind of the automatic biases that people unconsciously elicit. And I think it's very important that medicine address those factors. And so much of the training that's got into what we've called cultural competency up until this point has gone into those automatic biases and assumptions because communication, making people feel comfortable. These are all so important, such vital parts to this assumption about what it means to be understood by somebody who's literally taking your life in their hands. And if you look at cultural competency, really, we've kind of looked through as part of our structural competency project, a bunch of different assumptions. Here's a casebook example from the cultural competency casebook from the AAMC. And basically the stories that people tell in cultural competency are a Latina woman comes to your office. She barely speaks English. She refuses to take the medication, the medication that you prescribed for her. You also tell her to eat a healthy diet, and she's refusing to do that because she only wants to eat her native Cuban dishes, which are really high in fat food and stuff like that. And so the issue is basically you need to understand a lot about that patient. You need to understand their cultural background. You need to maybe learn a little bit of Spanish and understand a bit about regional dietary practices. All that super, super important. It's absolutely important. But I think there was an assumption in kind of traditional cultural competency frameworks that basically there was a paternalistic model that the danger was that race and ethnicity became another thing that the doctor, in a way, had to diagnose, right? In a way, the thing is the doctor walks in and immediately makes a decision about here's the race, here's the ethnicity, here's the issue. And I think what got left out of that particular framework, which I think is important, and I can say much more about this after, is that there were stories about this Mrs. Hernandez case that didn't get asked because it was so much of a focus on the individual race, the individual ethnicity. And one is when you're telling a woman like Mrs. Hernandez in that vignette to eat a healthy diet, a bigger question, a more important question is like, where do you get your food in the first place? Maybe Mrs. Hernandez lives right next to, Costco, and maybe Mrs. Hernandez lives in an area where there's a food desert and where all the healthy food and produce markets have been put out of business by Taco Bell and McDonald's and probably the best named short-lived fast food chain in the history of the United States, Grindr. The guy probably got fired, but it was probably a lot of fun for the year it was probably in business. But in a way, sorry, that was a very dated joke for the students in the audience. But basically, there was an assumption about food distribution networks that are inherent in telling somebody to eat a healthy diet, but you don't know that if that's not part of your awareness. Another point is when you tell somebody to take their medications and then you call them non-compliant, but you never ask, well, how do you pay for your medications in the first place? And so there's a level of socioeconomics. Also, when you're talking about race and ethnicity, I think cultural competency was really good at focusing on race and ethnicity, but there was no theory of racism, structural racism. In a way, when you focus so much on the presentation of race in the exam room, there weren't understandings of structural oppression, how oppression can happen beyond the clinic, how maybe even the clinic represents structural oppression. And if you don't believe that, just read this amazing, really amazing Ferguson DOJ report that lays out, here's what structural oppression means. And it's interesting because this was used to replace, basically after Ferguson, they were trying to train the police to be more culturally sensitive, which they should be, it's important and all those kind of things. But then you read a report like this and it's like, oh no, the racism, I mean, some police might have been racist, some police might have not been racist. But if you look at a place like Ferguson, there's decades of rezoning and changing the school boards and changing, where you live from a residential zone to an industrial zone and, limiting voting rights and things like that in a way. And if you think about health in that regard, which one's going to be have more of an effect on health? Well, certainly having a doctor who doesn't understand your background is important. But on the bigger picture, these upstream factors are huge indicators of health and illness. And why is that important right now, this new assumption about race and ethnicity? It's because there are new awarenesses of the ways that society itself can be and is the pathogen. In fact, we've never known more that society is the pathogen. So if you're changing from culture to structure, which is what I'm doing in this talk, it's important not to notice that we also live in the era of epigenetics, for example, where we know at a very tiny little level, like this teeny little level right there, that living in a resource-poor environment can produce risk factors that might last for generations if you don't change the environment. Neuroscience tells us that, this is slightly problematic literature in my opinion, but that if you live in poverty, it's bad for your brain. Imagine that. And also sociology and economics have factors like neighborhood effects and things like that. So we've never known more about the fact that social systems can influence, can create pathology in a particular way, and at the same time, doctors have never felt more helpless about these factors. Now, again, I think there was some conversation before about the interpersonal factors that can be more or less important and interesting and difficult. But in terms of just thinking about society as the pathogen, it's interesting to note that we have this huge literature here, epigenetics right now, all these other things. And then doctors are like, what am I going to do about it? And so there are these great RWJ studies, for example, that say that basically 85% of primary care and pediatric health providers agree that unmet social needs are creating worse conditions, and 85%, the same number, say I have no method. I got nothing to do about that whatsoever. And so in a way, I think this has led to a transformation. Everything that I've just told you to this point, you're wondering where is he going, and it's that it's leading to a transformation, I think, in the ways that medical education and medicine address race and questions of disparity. So whereas before we had a traditional disease, illness, race model that focused on the clinical interaction, which is, again, vital and important and key to care and diagnosis and treatment, but you're seeing increasingly that there are more and more frameworks, I think, emerging that complicate this question of the relationship between the individual clinical pathology and the larger structural pathology. And I don't want to make any claim that structural competency is anything but part of this bigger conversation, but I will say that I think I do feel like we kind of started a conversation in a particular way, but there's been great work of late. There was a great piece about structural racism and inequities in The Lancet recently that kind of gave a point-by-point blow of kind of the state-of-the-art knowledge in this area. There's also a great model that's coming out of Canada, and it's called cultural safety, and their point is basically, yeah, you can see all the structure you want, but culture still matters. And so it's important also to pay attention to culture, even if you're trying to debunk medical authority. And so there's a cultural safety model that I think is great to take account of. There are also just social justice initiatives that are happening at medical schools and residencies all across the country. One by medical students, for example, is White Coats for Black Lives, and they were having die-ins and protests and things like that. And so there's a lot of social justice work that's happening, I think, in relation to medicine that really is indicative of an earlier time period, the 60s or the 70s, when that happened. And then there's structural competency, which gets the biggest and most colorful slide, because that's what I'm going to turn to talk about, and that's really kind of our intervention and our part of this conversation. Now, for people who are not familiar with what we kind of talk about in that Social Science and Medicine article, we're positing a 5-part model for structural competency, and basically first it's just to recognize that structures exist, that structures shape clinical interactions. Then we're trying to argue that healthcare providers need to develop an extra clinical language of structure, so to understand things like sociology, anthropology, economics, philosophy. In other words, to broaden the medical canon, the medical corpus, in a way that brings medicine into conversation with some of these engagements, really more academic engagements with structure. We're then trying to get doctors to re-articulate cultural formations in structural terms. In other words, to say, Mrs. Hernandez came to the office and she doesn't speak English and she won't take the meds I prescribed for her. And instead of saying, and therefore I need to learn something about Hispanic culture, say, what are the other stories that, if you're just focusing on the exam, what does that leave out? And so re-articulation, I think, is the third skill. The fourth is to imagine what you can do. In other words, where does it get you to become structurally aware? How might that change the practice of the relationships between the healthcare system and society? And then the last is, obviously, that competency is slightly tongue-in-cheek in a certain way. Now, I think we should all be as competent as we can, and I'm all for it. But at the same time, I think the idea of structural competency is to say, wait, not everything is a medical problem. In other words, we're trained to fix everything by being so biomedical, but it turns out if you really want to understand structure, you need to partner with social workers and urban planners and community organizations and a bunch of other organizations. And so in a way to realize there's a limit to medical expertise, and in a way that's a good thing to recognize, that to address structure. Now, I know this goes against the grain. If you look at, for example, the guidebook for AAMC competencies right now, doctors are being asked to be religion competent and gender competent. And like, if you're a religion or gender scholar and somebody says, oh, I want to take your class and be like religion competent, it's a kind of laughable, right? I mean, the whole idea is that you're learning what you don't know. That's the lifelong process of these kind of studies. But when something gets interpolated into the medical system like this, competency is the language, but we're trying to kind of use that to show that we're arguing for more collaboration and more humility. Now, just one quote from our 2014 article. Structural competency is defined as the trained ability to discern how a host of issues defined clinically or biologically as symptoms, attitudes, or diseases, like the schizophrenia in Black men is one example that I used before, also represent downstream implications of a number of upstream decisions about matters such as healthcare and food delivery systems, zoning laws, urban and rural infrastructures, medicalization, or even about the very definitions of illness and health. And for any Stokely Carmichael fans, you can hear his voice going through here, because this is kind of a descendant of his definition of institutional racism. And so in a way, what we're trying to say is that's important. And again, if you just think about the frame, it's understandable why medicine might have said race is a diagnosis to make in the exam room, but it's at the peril of neglecting these things. And race has become central to what we're doing at Vanderbilt. And so the last part of the talk, I'm going to shift to talk a little bit about the Center for Medicine, Health, and Society at Vanderbilt. And I'm doing it as part, obviously, blah, 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 self-promotion. But the other part is really just to say that we're trying to do on the ground, how can you operationalize structural competency in a way that really changes educational outcomes, which is one thing we've been trying to do as a lab. So I'm shifting to the Center for Medicine, Health, and Society at Vanderbilt. I've been there 6 years now. I got when they recruited me, they said, "What will it take to get you here?" And I said, "I want a sliding green door," and I got a sliding green door. So if anybody comes and hangs out with me, we have a sliding green door. At first, it was like a big scandal at Vanderbilt, like sliding green door, that kind of thing. And then it turns out now it's like, if you look at the dean's Christmas card and stuff like that, it's like, here's our sliding green door. So it's funny how that happens, but we have a cool sliding green door. And in the room with the sliding green door, we're trying to create a new kind of medical humanities curriculum, a new kind of pre-health curriculum, one that focuses on health and illness in social, political, economic, historical contexts. In other words, like what I was talking about before. And we also have an emphasis on structure across our curriculum. Now, how can we do that? We redefined our curriculum in 2014 with many things in mind: medical humanities, critical race theory, other factors like that, but also structural competency. And the curriculum that we built in 2014, which was kind of revamping an older curriculum, had a number of new focus areas. So we basically asked all students to focus on global health, health behaviors and health sciences, health policies and economies, race inequality and health or activism, medicine, humanities and the arts, or critical health studies, which just means design your own major. So all the students that go through our program are going through one of those concentration areas. And how do we emphasize structure or structural awareness in those areas? Well, several of the concentration areas combine. You really kind of emphasize courses, so they're taking science classes and they're taking courses in things like urban planning, sociology, anthropology, and we have a lot of people who work on neighborhood effects, for example, so that plays out a lot in it. We've also recruited faculty who are actually studying kind of urban planning and health. So we have Amy Hamrai, for example, who teaches a class on designing healthy public. So it's actually just right there. Here's a class about it. We've also revamped a bunch of other classes on race and ethnicity and health. And we've also added structural immersion assignments to a number of our humanities classes. We have a English professor and a novelist who teach as part of our core curriculum. And we all kind of worked this through and workshopped it, but basically in that curriculum. And now a lot of the literature courses, for example, also engage with health disparities literature and go out in the community and look at things like roads. And we had a class that just looked at the racist highway that was built through Nashville and what that meant, and the literature and writings about it, and then interviewing people on both sides of the highway. So really trying to, I mean, people hate this when you say, here's what you should teach in your class. So we've tried to make this as collaborative as possible across our curriculum. But basically, we're doing all this while we also reward our students for doing different kinds of immersion classes where they're actually seeing how health is lived in the Tennessee community. And we've also created different kinds of events, looking at health politics and healthcare politics, like a conference on health in the South last year. We're encouraging different kinds of research projects working with different minority populations. One last part about structure is that our students have started to produce different kinds of structural interventions. I love this, but there was a class on food distribution, and they found out that Nashville was one of the worst cities in terms of food deserts, which is a controversial term, I realize. But basically, people living in low-income areas had to travel up to 2 hours to get healthy produce. And so the undergrad and medical students devised this system in which they first rented one refrigerated food truck, went to the local community, had meetings with people in the community, say, what kind of food did you like, partner with local organizations. Now they've got 17 refrigerated food trucks that are going, that are kind of trying to upend this idea of a food desert, and now it's becoming a kind of a model across different parts of the country, this idea of the kind of mobile market. And so our students really are trying to get out there in the world. And we also, I think it helps, hired a lot of people like Amy and Ken McLeish and people like that who are working on this. Now, this hasn't hurt our enrollments. In fact, with our newly revamped curriculum, we're now nearing about 600 majors. We're the second biggest major on campus, and at least at this point, the fastest growing major on campus. We've also expanded the kinds of students we get, and so we started off mostly as pre-med, and now we're getting students who are going into global health and finance and business and other factors like that. So we've expanded our student body. We've also just, obviously, when you hire people, expanded the number of courses we teach. So in the last 10 minutes before we get to Q&A here, I'd just like to talk about some of the research that we're doing on this. We've basically developed an assessment strategy for answering a question that might be in the back of your mind, which is great. You're teaching all this structural stuff in your curriculum. How are you going to assess if your students learn that or not? And we've been working a lot to demonstrate core structural competencies that we think our students should be able to master, things about structures influencing health, about the resonance between biology and social worlds and factors like that, and really in relation to race. So can you talk about race on an individual level, but also can you talk about race and racism, basically, in the same way? Now, what do you do when you have a question like that? Well, you experiment on your students, and that's what we're doing. We did a big project that I'll talk about today, just in this last bit, where we studied basically our graduating class in 2015. So about 105, 107 of the 127 graduating seniors. We compared their response to just straight up pre-med science majors. They're kind of equal numbers of science majors and MHS majors. So these are just the straight science majors. And to make it interesting, we threw in a bunch of freshmen. The findings that I'm going to tell you are coming out next month in Social Science and Medicine, so I'm happy to send around that link if that would be of interest. But basically, we devised a kind of exit exam for seniors that asked them different kinds of questions. First, we just asked them, how confident do you personally feel in your ability to think about race and ethnicity and health politics and things like that? And what you can see here is just in relation to self-reported knowledge. The blue graph that's taller are the MHS students. The white graph are just straight up science pre-meds. And so basically our students were exponentially felt they were more confident in talking about the relationship between SES and health, knowledge of the healthcare system, knowledge of an amazing piece of legislation that used to be in this country called the Affordable Care Act, things like that. And so our students just felt more comfortable talking about these issues. Then we asked a kind of open-ended question, which is, in your opinion, what are the three most important influences on people's health? Now, you're going to laugh because this is kind of replicates what we heard in the panel right before me, in a way. But we just said, tell us what you think the three most important influences are on people's health. MHS graduating seniors said, I mean, this is awesome, right? Their main terms were socioeconomic, education, access, environment, all these terms that are like really outward focused, outwardly looking. Then when we asked the pre-meds, what are the most important factors on people's health? This is what their word cloud looked like. Basically, every single thing was genetics, and then some other stuff. So a big disparity there. Then we were kind of sneaky, but we gave them that cultural competency casebook example just to do what I've been talking about here, which is we gave them the casebook thing, and we just basically said, read this for us. And we didn't say be structural or cultural. We were just curious what response they might have to a traditional cultural competency vignette. The MHS students, God love them, said, Mrs. Hernandez may live in a food desert and be able to obtain the necessary fresh vegetables to improve her diet, So a very outward-looking structural thing. Pre-med science majors, since Hernandez is a foreigner, she might trust or listen to the doctor, also language barrier. So I think beyond just the obvious idiocy of this answer, it's also important to see that basically the MHS student was talking about something that was beyond the framework of the individual doctor-patient interaction, the bigger kind of social context, whereas the pre-med student was talking much more about, oh yeah, it's just an interpersonal dynamic. We also asked students about childhood obesity in the South. In other words, why does the South have more childhood obesity? And we asked them two things. We asked them to just check if they thought it was more cultural, genetic, health related, and then also just give us a few sentences about why they chose a particular answer. Now, here again, the MHS students were much more likely to choose culture and structure. So MHS students were more culturally and structurally competent than the traditional pre-med students. And the answers we would get would be things like this. For the pre-med science major, they talk about Southern comfort food, but a lot of stuff about individuals dictate their own choices and lifestyles. Lots of stuff about, again, individual choice, individual doctor-patient interactions. The MHS majors just had so much to say about this, but it was about low family income. It was about incomes correlated with obesity, poorer states, structural racism, factors like that. So they were just all over this as being, let me tell you something about obesity. And then instead of pathologizing the individual food choice, which is what I think we're trained to do a lot of times as Americans, instead they looked much more broadly at the structural factor. We also asked about the overrepresentation of African American men in cardiovascular disease, and here as well, MHS students were more structurally and culturally competent, and the answers, again, went along this binary of the individual or the genetic versus the larger cultural or structural. So the pre-med science majors said stuff like lifestyle differences between two groups, meaning black and white groups, as if there's like a black or white lifestyle. I mean, I'm probably living the white lifestyle and I didn't even know it. But basically that. Or if the problem is race, it's probably genetic, a lot of stuff like that. And the MHS majors, again, talked about neighborhood factors. They talked about institutional racism. They talked about socioeconomic status. So great success story up until this point in the story. The last part of the story is we didn't want to make the automatic assumption that race equals minority or that anything like that. So we then added in several questions about whiteness. In fact, we gave them one of those pharmaceutical ads like the ones that I was showing you, seems like about 3 hours ago in my talk, and just asked some questions about what's this. We just asked the same question. How do you read this? Now, it turned out that all students were incredibly good when we gave them ads like this. They were incredibly good, and when we asked them what's the message, what are the factors, they were really good at blaming the pharmaceutical industry. That was kind of the standard story. So it's kind of like economic factors are huge, pharmaceutical factors are huge, pharmaceutical companies make all these things. So everybody loved to bash medicalization, certainly. And even the MHS majors who talked about race and talked about whiteness, where they got with that wasn't, and therefore whiteness is the norm, or whiteness is whatever. It was all, and therefore whiteness, blah, 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 bash the pharmaceutical companies and stuff like that. And so there was a lot of that kind of thing. But as a whole, students were much, much less able, even though we addressed this very directly in a number of our classes, but the rhetoric, the language around whiteness was far, far, far more impoverished than it was for everything else I've talked to you about. And so we're trying to think now, what other ways are there to do, what else is there to do about this, and obviously this is a bigger cultural problem, which is just whiteness as invisibility, whiteness as the norm, whiteness as the baseline. But certainly we were really trying to pay attention to this, and it still really didn't move the needle exactly all that much. And so in general, whiteness is, I think, the next frontier if we can think about it, but I think it's going to take a different framework. But overall, what we found in our research was that our students were much more likely than traditional pre-med students to address structural factors and when they explained health outcomes. They were more likely than traditional pre-med students to also think more distally, as I was saying before. In other words, think about the neighborhood effect, the health delivery system, the institution, and not just about the clinical interaction. Now, again, taking nothing away from the clinical interaction, but there was this resonance, I think, that the college students were starting to assess, whereas I think the pre-med students really were in this regime of the individual choice and genetics, which again is super important. I mean, actually Vanderbilt's one of the top places now for precision medicine. Sorry, I'm sorry. But my point is just that the danger is that it reifies these problematic binaries. That in a way, if you're just thinking about the individual choice or the individual DNA, that's important. That's really great. I'd like some individual DNA myself, but the point is that the problems are this, really, in a way, that it reifies that. Another important point we found, just taking who's majoring in what out of the equation, this is a graph about just how many MHS classes, how many classes about race and disparity did you take. So if you answered your vignettes and you didn't identify, you identified zero structural factors in your explanation of the heart disease and obesity vignettes, that correlated with mostly with students who had taken no MHS classes. And the more classes that people took in things like race and disparity and economics and sociology, the more likely they were to identify structural components in that factor. Now, why is that important? I think that's important because for a long time we've said the cultural competency approach is to make you more sensitive. You should be more sensitive to other people's cultural backgrounds. And that's cool. I'm all for that. But what we're trying to show is actually structural awareness is a skill. It's a skill that we can teach. It's a skill that we should be teaching in a way. And so in a way, it takes the question of individual identity out there. I don't know if we make people more or less racist, and I don't know if that's a goal of a college class in a way, but I do know that we can teach people to think, to see the world differently in relation to these issues, and doing so calls on traditional knowledge bases like public health and sociology, anthro, humanities, things like that. And so in that way, I think it gets us out of that question of the identity question, which I think has hampered for a long time this cultural competency question. Now, of course, it's also the case that our students did really well in the exit exam because they were reproducing the stuff we taught them in our classes. And that's no doubt true. I accept that, but that was kind of the idea, right? That's why we were teaching them that stuff in the classes in the first place. And that's important not just because, yeah, they want to get an A in our class, but also because testing bodies are very slowly recognizing this factor as well. And so there's increasing recognition on the MCAT, for example, where social and behavioral sciences and critical thinking are becoming part of this skill base that students should be recognizing this. So hopefully we're saying there's a knowledge base for this that should be that. Another thing is all the parents are like, well, is my kid going to get into medical school or something like that? And it turns out another fact that has made us very unpopular at Vanderbilt is that actually, according to the health advisory data in 2016, not only did everybody get into med school at good rates, but we got in a little higher than traditional pre-meds. And so in a way, I think this concern of is paying attention to race, to structural racism, factors like that, is that going to hurt my chances of getting in? And it turns out our students were having no problem getting into medical school in relation. Now, why is that? And I think that is, in a way, because think about it. What do you have to know when you learn about structural racism? Well, you have to learn about neighborhoods. You have to learn about how diseases flow in society. You have to learn about power gradients, all these things that are really important to epidemiology, to biostatistics, all these other factors. So to really understand structural racism, it's all these things that are really important to also understanding health and illness. And so in a way, I think that skill set is a very useful skill set for training the next level, the next generation of doctors. Before I finish, just two last points, which is I think that in a way, we're all in this together. It kind of got me upset. There was an article in The Lancet that was basically saying, it's not structural competency, it's this. Just like I'm sure we said, it's not cultural competency, it's this, or something like that. And I don't know. I mean, we can argue which thing is right. I don't really care if they're right or whoever's right or something like that. It's really that there are issues of race and equity and injustice and advocacy that need to be addressed at this point in time in our society. And the best way we can do it, if we can all collaborate, I think the more important. But I think now's the time for collaboration in a way, for alliance formation between people who really care about these issues. Not to say those guys were wrong and I'm right or anything like that. It's really to say, how can we collaborate? Now, unfortunately, that hasn't always been the case. And I think that the voices of medicine that have spoken out politically, in recent years at least, have been the opposite of advocates. And so if you think about what are the main kind of medical voices in society, it's people like Rand Paul, Ben Carson, creepy speculum Uncle Sam. No, okay. But other voices that really talk about the individual factor, the individual choice, the individual responsibility. And I think to this point, medicine has lost a language that it really had in the 70s, for example, in the community mental health era and the community health era, to talk about the importance of communities. And I think that all this groundwork of all these organizations and different approaches to social justice hopefully will create a more socially active, socially conscious venue for medicine. And ultimately, I think, as I was saying before, that really what we're trying to do is create a kind of medical humanities, interdisciplinary approach that really helps us rise to the temporal challenge of our time, which is, on one hand, to treat people in times of need. I think when you come to the doctor, you're in crisis often, and you want somebody who's an expert. And so in that sense, I'm not trying to take anything away from that. And at the same time, look at the kind of larger social biases and inequities and blind spots that shape our very definitions of health and illness before doctors and patients even enter exam rooms. Thank you.
Can you tell us if your major and your center does work also focusing on global health, or is it mostly US-based? And the second question has to do with the internships, where you're sending students out, which I think is great. And I'm wondering if you also have methods courses to enable that, because it's one thing to I understand the importance of community, but as a faculty member, I'm very wary of just sending kids out and the burden that sometimes can be placed onto local community institutions if we don't train our students properly.
I'll just say, first of all, in terms of global health, absolutely. We have a Brazilianist, Dominique Beag, on our faculty, and if anybody wants a job, look on our website. We've got an open call job search right now for an assistant professor of global health. So we're moving in that direction. Vanderbilt is also trying to copy you guys here and do a lot of global health. So I think we're slowly moving in that direction. Now, a lot of stuff that we started with was admittedly somewhat US focused, just as the first step, and we talk about that there. But I think we're very aware of this issue, and we had a global psyche conference last year that was part of this initiative, where we were trying to broaden the conversation. So that's certainly something that's happening as the second stage of our growth. Methods is so important, and we've hired Tara McKay, who's a sociologist, and we've got a bunch of great methods classes on doing really community-based research right now. So a number of our faculty are teaching those methods classes because we ran into that same problem, which is we just thought, go out there and hang out and stuff like that. And it turned out the students just went and made coffee for people and stuff, which is cool. I love coffee, but it was really like, it was a problem for the organizations, but it's also a problem for us, because then when we got the papers back at the end of the semester, it was kind of like, oh yeah, that's it. So we have 3 solid methods classes as part of the curriculum now. I skipped over it really quickly, but we have a master's program also. I know there's a great master's program here at UNC that's kind of similar. And methods are a huge part of that program as well.
I was wondering if you could speak to what you're doing with the medical school and the medical students. What are you doing with them?
So it's interesting at Vanderbilt. It's been there's been some stuff happening between the medical center and the college at Vanderbilt recently, so we started off having lots of MDs teaching in our curriculum, and there was a lot of overlap. This is public record, but the med center and the college have gotten divorced over the last couple of years at Vanderbilt, and so we're trying to figure out different ways to rekindle those connections in ways that they're a little bit harder for us right now. We've got a MHS med student group. That part's really cool and easy, but we've got a lot of alumni who go to the Vanderbilt Med School. So we do a lot of outreach there. We also have a lot of gap year students who come back and do our master's program in their gap year in med school. So there is an ongoing exchange at the med school level, not as much as I'd like, but it's hard with the curricula there. But really the med center issue is one, just to be honest, that we're working that out right now, because it's not as easy as actually it was when we started the whole project. But of course, I think what's behind that question is, it's great I mean, if you think about teaching college students, right, on one hand, they're the perfect audience for these complicated ideas about race. And what used to drive me bonkers is it's like when I was in med school, you got a 3-hour lecture on race and there was a pre and post test. And it's like, are you less racist, yes or no? Something like that. And you think about it's the same thing as like reading Mein Kampf or something like that. Like you're just cherry picking this idea, but it turns out like you can't really change that in 3 hours. You can change the test maybe or something like that, but you can't really change that in 3 hours in a way. And so part of the issue is we're trying to push it down to undergrads because you can have a semester-long engagement or a curriculum-long engagement with really complicated ideas in ways that then play out over the rest of their careers. But I think behind all of this is what happens when they become residents. What happens when they become doctors? Does it mean that they're going to be more socially conscious, or is the system going to just beat it out of them? Or they just it's like this higher level professionalization narrative. And I think that's the question that we don't have data for that yet, but it'll be interesting to see as our program's not that old. So as we get in touch with people down the road, whether it would change their practice.
I was just wondering if you were thinking about or trying to study the students as they go through med school. And part of the reason I asked that question is because I teach both undergrads and I teach history of race and medicine to undergrads and in the med school. And I'm really fairly shocked by the ways in which things they knew, it gets lost, how the power of biomedicine just makes it really hard to retain this nuance. Now, that said, what I also see as they become residents, or finish residency, some of it comes back.
Oh, really?
So
I believe that.
There's not an absolute loss. They suffer through residency, especially when they're working under certain communities. Those residencies can be very challenging, and they do somehow retain some of it. I guess and a really quick, simple question is, do you have a community health or public health undergraduate concentration at Vanderbilt?
There's no School of Public Health at Vanderbilt. So we have 2 public health scholars in our center who they don't know how they ended up in the College of Arts and Science. We're in Arts and Science, right? So we're teaching center unit, stuff like that, and they're just like, where's the NIH grant, stuff like that. But no. So we're teaching. So we have 2 public health scholars in our unit, but there is no School of Public Health at Vanderbilt. So
and that's probably a benefit, right? In a lot of ways,
I'm not complaining.
Because the public health is increasingly rooted in a biomedical model. So I think that's one of the powers of your program, actually.
It's beneficial for our program, but it's funny because every time we submit a paper about structural competency, or anybody submits a paper about structural competency, I invite all of you to try it. Everybody writes back and they're like, well, isn't this just social determinants? Isn't this just like and so there's like all this work we have to do is say, yes, we agree that there are disparities and things like that, but we're actually trying to critique the larger frame because we feel like just saying here are fixed black and white groups and here are health outcomes or things like that doesn't exactly get at what we're trying to do. And so in a way, there's also a tension just methodologically, which again, I think it's easier at the undergrad level.
You mentioned briefly that whiteness has been a really trenchant kind of moment, and alluded that you had to adopt a different strategy for addressing it. I wonder if you could speak to how you might be needing to pivot.
Mm-hmm. I just think that that's a societal problem, and I think it's been a problem of public health and medicine along the way and stuff like that, that when you talk about disparities, it becomes a coded way of talking about race, and race becomes a coded way of talking about minority populations. That's important, right? Because there are profound socioeconomic issues and access issues and all those kind of issues, but I don't know, it's hard when you think about whiteness and disparity together, for example, even though if you look at a lot of the stuff that's happening about like poor white populations and all the great econ literature that shows how like white men are the one group whose life expectancy is declining in this part of the country and things like that. But just talking about that in this context has been different because I don't know, I kind of go back and forth about this. And as I said, I'm writing a book about whiteness right now. And I go back and forth because on one hand, it's like, okay, let's talk about blackness and let's talk about whiteness. Well, I don't want to frame it that way. Or it's like, let's talk about apples and oranges, and I'm going to sneak in some whiteness on the side, or something like that. And so there's the kind of that kind of way, or the Tim Wise way, the beat you over the head way. And I just think that this is a bigger issue. I think this is a bigger issue for race studies, for the way we think about this, and really for American society about what does it mean to talk about whiteness. Now I know this because, and I apologize, I'm going right from here. I can't stay. I'm missing the party tonight. I feel horrible about this, but I do all this media in New York, so I'm flying from here to New York. And anytime I go on TV and I talk about anything in the world, it'll be relatively cool. But if I talk about whiteness in relation to guns or health or something like that, like just the stream of stuff I get on Twitter about, you race traitor, you sell out. I just think the rhetoric around whiteness as a category, on one hand, it's the urgent issue of this particular moment, really, in a way. And on the other hand, part of the issue is because we haven't really developed or come to terms with this invisibility, which I think is important. So I think that it's really the next phase of something bigger than ourselves. And I also think we're going to try to work it out. I know that's kind of a non-answer to the question, but I welcome any suggestions because I don't have a solid answer. I don't think the answer is we're just going to teach a class on whiteness, even though if anybody wants to come, we are having a conference on whiteness in the spring. So, yeah.
So I'm a third-year resident at Duke, and I absolutely love your talk. And the reason why is because I was born here, but I grew up in Brazil, where I spent 24 years. It was interesting that when I came back, I was trying to take the pre-med courses for residency. And I was taking this pre-med course where, probably the students, similar to the one that you probably interview. And so we were talking, she was asking me, what you were doing here? And then I was telling her that it was interesting to go to medical school. And she said, whoa, this is going to be a very challenging thing for you because a lot of American students want to do the same. And when I told her, well, I think I'm American as well because I was born here, her answer was that, I don't mean to be offended to you, but this is for true Americans.
Oh.
And on the back of my mind at that day was that, wow, this problem is even before when I'm in med school. And I went to medical school here and residency here, and I can tell you this is a problem that I think at some point it started early on. And I also question myself, where should we start to do this type of training that you are saying, which I think is amazing? Should we start to do even earlier than pre-med students, perhaps high school students? And I don't know if there is data out there, and that's my question for you. Where should we start to try to think about to change those bias on the kind of the early generation? Because I think by the time they get into the residency or even medical school, my thought is that maybe perhaps it's already going to be a very challenging test.
Unless we develop more transparent ways of talking about whiteness, this rhetoric is just going to end up reifying, talking about race means talking about minority groups. And so I think we have to be so conscious all the time about the fact that we need to develop much more language for talking about majority groups in a way. And so I think there's a danger of reifying that with this approach if that doesn't happen. But I think that, on one hand, I guess the question is what's the value of an education, right? In other words, is this something you can train people? And so you can see from why I like the competency issue is that I feel very comfortable as a college professor when this is a skills-based conversation. In other words, I'm not trying to change anybody's party affiliation. I'm not trying to change anybody's sensitivity. But I do think when we think about these as benchmark skills, my hope is that the awareness comes along with that in a certain kind of way. So that's my personal answer. I would also say that there are great models, and if you look at our social science and medicine piece that comes out next month, there are great models in the UK and actually in South America that are also engaged with kind of politics from more kind of class-based Marxist kind of things that are also trying to engage with these issues. So I think that hopefully we're going to have more models out there. And again, I also think it's a question of how much do we want to change society in a way. But it does drive me crazy that medicine, give me a break. To keep your mouth shut for these great Affordable Care Act debate where there's a possibility of expanded healthcare, more teaching organizations, preventative medicine, all this kind of stuff. And the voice of the AMA, and the voice of all these other organizations totally silent. The only thing you hear is about reimbursements, and it's let's take a unified stand for what we stand for in a way. And there was no language. So hopefully the grassroots organizations are going to do a better job, because I just feel no matter how you feel about that, I just think that there was a conversation that wasn't about reimbursements, but that was the conversation that medicine decided to have. I know we're just about out of time. Why don't we just pull together a bunch of questions? Would that be okay?
I wanted to return very briefly to Ms. Hernandez before you go. So my question regards sort of blaming of the patient or activity surrounding the patient's behavior that is out of context. There's no structural analysis, there's no context for her behavior, there's no understanding, which of course multiplies your treatment options. It also multiplies your sensitivity, your understanding, your rapport with the patient. But I feel that having a structural approach, while it offers better patient care for those reasons, it then turns to say, well, it's not Mrs. Hernandez's fault. It's the food desert's fault. It's the mold in the housing's fault. It's whatever. Not necessarily blame shifting, but I want to know about in the clinical setting, when it's the doctor and Ms. Hernandez again, when you have this structural analysis, how does that change the treatment? She's not taking her pills. Maybe it's the fault that she can't get to the pharmacy, but she's not taking her pills, right?
Perfect question.
This is what I want to know about Ms. Hernandez after the structural approach.
So my question is, in the UK, for the first ever time, at the end of last year and the beginning of this year, junior doctors, which means everybody up to consultant level, went out on strike and refused to work because they didn't like the system. That's the first time that British doctors have become politicized in that way. What is the equivalent in North America?
I think you just got your. I think the audience just answered.
Hi, my name is Perry Tsai. I'm highly involved with the American Medical Student Association, which deals with a lot of these issues and tackles these issues and seeks to develop leaders in these issues. And so I was hoping, and you sort of got into this, and I think it relates to some of these questions, is what do you envision more explicitly of how future physicians or health providers can be engaged politically and make these upstream changes? Because in the clinic, you often feel like your responsibility is to your patient and not necessarily to your population or community. What does that look like outside of the clinic?
Wonderful. And one more, right up there, yes.
My question is actually similar to one that's already come up, but about that balance between the structural and individual.
Yeah.
Mostly because I think part of what health humanities can do is access the individual and the singularity of some experiences.
Absolutely.
In ways that maybe other disciplines can't. So how do we kind of balance that?
So, this question of what Mrs. Hernandez can do in a particular way, I mean, and really the bigger question is kind of what happens to individual agency. So I think part of the intervention we're trying to say is that and we're kind of erring on the side of too far, maybe in a particular way, to say it's not just people who have race, it's structures that have race, it's diagnoses and medical systems that have race in a way. And then I think the blowback question to that is then, okay, how does that change the conversation in a particular way? And I think even in these questions, you've heard, I think, the great unanswered yet diversity of possibilities, I think, for thinking about that. On one hand, I think it's a brilliant comment, which is you don't want to take away Mrs. Hernandez's agency, right? She's also the one who decided to go to the doctor. She's also the one who's probably paying the copay, maybe, and taking the medications and things like that. And so you don't want to just say this is entirely a structural story. And I think it's also a fair critique to say it's also a cultural story, right? I mean, there are cross-cultural differences that we still need to pay attention to. So you also don't want to efface culture. And I think that's kind of an issue if you think about structural competency just on the clinical level, which I think is, I will admit, a caveat that it's that we don't want to, and that's why, in a way, if anybody hasn't looked at that cultural trauma stuff that I had the slide up before, it actually does a really beautiful job. It's come out just recently of synthesizing a lot of these issues, which is cultural background's important, ethnicity is important, empowerment's important, and things like that. So I think there are, version 3.0 or 6.0 or something that are coming that are doing that. I think that's kind of where we're going next, is in line with that question, because certainly disempowering or taking away some agency is not the goal here. But I also think that what we're trying to do is also say, and I also am so sympathetic to the idea that you have 7 minutes check the kidney and the pancreas and the elbow and whatever else you do, and that kind of stuff, and fix society and justice and stuff like that, and so in a way the pressure on the doctor. Now there are ways that what's the immediate clinical salience of this are being addressed by Joel Braslow and Philippe Bourgeois, for example, at UCLA, who are doing this. They're taking structural competency, but they're doing a structural vulnerability checklist, for example, for emergency rooms that was in one of our earlier special issues. There are other people that are doing like, okay, how are you going to operationalize this at the clinic level? But ultimately, this is a political intervention, to be totally honest. And in a way, what we're trying to do is also put grassroots pressure on the politics of health and healthcare system. Because I guess the take-home point for me is that there's not a counter language to this individual narrative, which is so prevalent, and it's going to get worse with this FACO healthcare debate that we're going to have again in 2 weeks and stuff like that. It's all about states' rights at the level of your individual body or something like that. And so I think that there needs to be a counter rhetoric. And so ultimately this is a political project, I'll be honest. And in a way, what we're trying to do is create a grassroots rhetoric that pushes back on the superstructure of medicine in a way that creates a kind of common knowledge that's a kind of unifying rhetoric. And I think that's really the issue, while also saying to doctors, you actually can address social justice issues in the exam room. So I don't want to say that that's not a clinical problem. It is as well. And certainly we know that from the Black Panthers on down that the individual clinical encounter is incredibly political encounter also, and our bodies ourselves and everything else like that. So let me just say two last things before I finish. Again, I really apologize for having to run to the airport because I want to hang out with everybody. If you want to contact me, just tweet me at Jonathan Metzl or anything else. We can just keep the conversation going. And just thank you so much. Really great conference, great audience. So thanks.